Good afternoon, everybody. Myself, Dr. Sudipta Mukherjee from Tata Medical Center, Calcutta. I'd like to thank the organizer for involving me and making me a part of this academic activity. And in next 20 minutes or so, I will talk on volume status estimation in ICU. Now, volume status estimation in any critically ill patient is extremely difficult and challenging. And so it should always be target driven. So my suggestion will be, and the most important slide of the whole presentation is, do not assess volume status of a patient unless there is an evidence of inadequate tissue perfusion or there is any evidence of volume overload. That means there is a problem at the target organ. So if you look at the distribution of fluid, the whole body of a human being contains around 60% of the body weight is water, and 35% is around extracellular fluid, and intracellular fluid contains around 65%. Among this extracellular fluid, around one-fourth is plasma fluid and three-fourths is the interstitial fluid. So now among this plasma fluid, the whole plasma fluid does not contribute into the venous return during the fluid resuscitation or hemodynamic activity. Among this plasma fluid, a volume which is present in the capacitance vessel of the body, which is called unstressed volume, does not participate into the venous return. The stressed volume, which also generates the mean capillary filling pressure at the tissue level, is causing the venous return depending on the pressure difference between the mean capillary filling pressure and right atrial pressure. When the mean capillary filling pressure increases, the venous return increases, and also at the same time, because of this increased pressure, there will be increased capillary filtration. We all know that fluid is a drug, so we have to give it in an optimal way and keep the patient's volume status within the normal volumic range, because both hypervolemia and hypovolemia causes poor outcome. Hypervolemia we are all aware of, so presently we are not practicing any form of liberal fluid therapy, but we need to remember that hypovolemia, because it causes poor tissue perfusion and can cause renal dysfunction, is also harmful. So whenever we are talking about fluid status of a patient, we are basically assessing whether this patient is going to be fluid responsive. That means whenever we are giving some fluid to this patient, can he or she increase his cardiac output to improve his tissue perfusion? At the same time, there will be another terminology will come into discussion is the fluid tolerance. So as we discussed that whenever we are giving fluid, there will be increase in the mean capillary filling pressure, whether this mean capillary filling pressure is leading to a tissue edema. So whenever we are giving fluid to a patient or assessing the fluid status, we have to maintain a balance between fluid responsiveness and fluid tolerance. We are all aware of this Frank-Starling relationship, that if the heart is working or the ventricle is working on the steep part of this Frank-Starling's relationship curve, then with increase in volume status, the cardiac output will increase. But we, at the same time, we need to remember that whenever we are giving fluid and there is an increase in the mean capillary filling pressure, gradually the difference between the right atrial pressure and the pressure at the capillary level will decrease, and progressively the venous return will fall. So whenever we are targeting a tissue perfusion, we have to target the intersect between these two lines. And if I put it more lucidly, the fluid which is situated below this nozzle does not influence the flow rate through the nozzle. It is the fluid which is situated position above the nozzle. And the pressure. So how can we increase the pressure? If we increase the volume of the fluid above the nozzle, that is called the stress volume, or by any means, if we can mobilize some amount of fluid from the unstressed volume into the stress volume. And what is the target? The target is to increase cardiac output. And cardiac output depends on the heart rate and the stroke volume. So stroke volume will be influenced by the end-diastolic volume, which eventually lead to the myocardial stretch and will influence the contractile strength. And whenever we are targeting to increase the cardiac output, there must be a challenge like compromised tissue perfusion in terms of hypotension, decreased urine output, decreased capillary refill, altered sensorium, or low CO2 or high lactate or base excess. We all know that lactate has been extensively used to assess the volume status And for the initial resuscitation of septic patient, even surviving sepsis guideline has emphasized multiple times its importance. But we should remember that it is applicable in the initial phase of resuscitation for the first 3 to 6 hours. Beyond that, in ICU patients, there is a multiple reason for high lactate. So in a septic sick ICU patient, high lactate does not mean patient is hypovolemic. Now, whenever we are using use the term volume status, we are basically talking about volume responsiveness of the patient. And let's see what are the options and the modalities we have to assess the volume responsiveness in ICU. So there may be some static hemodynamic parameters. It can be pressure indices like right atrial pressure, central venous pressure, pulmonary artery pressure, maybe volumetric indices like right or left ventricular endostolic volume, right and left ventricular endostolic area, intrathoracic blood volume, and endostolic volume. So whenever we are talking about volume status, probably the volumetric indices will be more sensitive or specific. But it is very difficult to measure these volumes. So what we do, we usually measure the pressure indices and try to extrapolate those data for assess the volume status. And this relationship is only applicable if the conduit has a fixed compliance. There are other dynamic indices like delta down and delta up, systolic pressure variation, pulse pressure variation, stroke volume variation, peak aortic flow velocimetry, this we will discuss later. And there are some indices which are based on mechanical ventilation induced variation of non-stroke volume derived parameters like plethysmography delta PIP. Now let's see, whether does central venous pressure predict fluid responsiveness. We all know it does not. And this article has clear systemic review and meta-analysis has proved that the volume status of a patient can vary significantly, and it may vary up to 2 to 3 liter with the same central venous pressure. But what if you don't have any other modality? Can we use it? Studies has also shown that there will be a rise in cardiac output by 0.3 liter per centimeter square with a change of 2 millimeter mercury of right atrial pressure that indicates that heart is functioning at the ascending part of the cardiac function curve. So, if the central venous pressure is very low, there is a good possibility this patient will be fluid responsive. And when the central venous pressure is high, that is more than 10, when you are measuring at the sternal angle or by convention by 2 to 14 millimeter of mercury compared to the mid axillary line, it indicates the central venous pressure is high, and there is a good chance that this patient will not be fluid responsive. At the same time, if there is a respiratory variation of the central venous pressure, there is a good possibility that this patient will be volume responsive. And if there is a prominent Y descent, it indicates Y descent usually indicate the immediate fall in right atrial pressure at the start of the systole. If this Y descent is prominent, then that indicates a ventricular filling is limited, indicating cardiac restriction. And if the Y descent is more than 4 millimeter of mercury, it predicts a lack of volume responsiveness. So my point or the message I want to give that whatever the modality you have, you need to utilize it at its maximum. Even the central venous pressure, which so-called is not a good marker or not a good indicator of volume status, can be utilized to its maximum to assess the volume status of the patient. What are the other things we can do? We can work on the Frank-Starling's curve, and we can check whether there is a preload reserve in the patient by giving a small preload challenge in terms of mini fluid challenge, where we will give a small volume of fluid bolus over a short period of time, or can do a passive leg raising test when there will be an auto transfusion of around 500 ml of blood, and or there may be end expiratory occlusion test where we will increase the preload of the left ventricle and will look for increase in the cardiac output. So studies have shown that even if we give a small volume of fluid like 100 ml colloid very fast, that is within 1 minute, it can predict fluid responsiveness. And if there is an increase in cardiac output by 10%, that indicates this patient is probably going to be respond to fluid or be able to increase its cardiac output. Passive leg raising test we are all aware of. So we start with patient will be 45-degree head and up, and after that it will be head down with leg side up by 45 degree. And it shows that after PLR, the aortic blood flow changes is similar to its response with a 500 ml of normal saline. And if the patient is volume responsive, there will be increase in the aortic flow velocity. Similar result can be obtained whenever we are doing an end expiratory occlusion test in a mechanically ventilated patient, because at the end of expiration there will be progressive increase in the venous return to the left ventricle and leading to increased cardiac output. And if you look at the sensitivity and specificity, uh, in case of um, end expiratory occlusion test, the ROC of the area under the curve is more than 0.9 with a threshold value of only 5% change in cardiac output or arterial pulse pressure. Now next is the most echocardiography, which is probably the most common modality we are presently using for assessment of the volume status. So either we are looking at the left ventricle, whether the chamber is empty or not, whether any evidence of kissing sign, all the walls are moving properly, whether there is the IVC is full or there is a significant respiratory variability present or not, in terms of mitral flow velocimetry and the E and A ratio. And what we can also measure the cardiac output by VTI and by measuring the aortic root diameter. And with this, all these modalities, with this measurement, we can make a protocol to assess the fluid status of the patient. So if there is overt signs of hypovolemia, like small left ventricle, hyperdynamic left ventricle, small right ventricle, IVC less than 1 centimeter, and dynamic LVOT obstruction, it indicates patient is dehydrated. We can check for a VTI or stroke volume variation with a fluid challenge, and it is positive. This patient is probably fluid responsive and should repeat the fluid status till the patient has optimally filled or the target end organ perfusion is achieved. If this is not over, that is, the hypovolemia is not over, then we have to look whether the patient is spontaneously breathing or in mechanically ventilated. If the patient is sedated and paralyzed and mechanically ventilated and with a tidal volume more than 7 ml, in that situation we can go for aortic respiratory variation like stroke variation, VTI and peak velocity, IVC respiratory variation more than 12 centimeter. If these things are present, then patient is probably field responsive, and in its absence, probably we have to look for other causes of poor tissue perfusion. If the patient is spontaneously breathing, or there is any arrhythmia, or spontaneously breathing effort is there, or there is a significant LV or RV dysfunction, we can go for passive lip raising test, or we can look for the change in the velocity time integral or stroke variation before and after 1 minute of PLR. Again, if the patient is responsive, there is a positive result, the change is more than 10%, that person is probably fluid responsive. Again, we can also assess the fluid responsiveness of the patient by using heart-lung interaction. So whenever patient, and for this, patient have to be sedated, paralyzed, or on mechanical ventilator. So what are the physiological changes happen when the patient is having inspiration? There is an increase in the transpulmonary pressure and increase in the pleural pressure. As a result, there will be decrease in the RV preload and increase in RV afterload, leading to decreased RV ejection, and there is decreased LV afterload and increased LV preload, leading to increased LV ejection. So at the end of inspiration, the systolic pressure, pulse pressure, aortic blood velocity will be maximum. And at the same time, at the end of expiration, all these pressure volumes will be minimum. And by this, we can check whether this patient is going to be fluid responsive. And all the measurements, whatever we have mentioned before this, these are all static parameters. If we measure all those values, data like arterial waveform, IVC diameter, SVC diameter, VTI of the left ventricular outflow tract, and we can measure it over a respiratory cycle, then we can check for the respiratory variability, which makes it a dynamic parameter and is a better predictor of volume status of the patient. Pulmonary artery catheter, it used to be as utilized for volume status assessment before by the measurement of pulmonary artery wedge pressure or pulmonary artery occlusion pressure. The studies like ESCAPE trial and Pacman trial has shown that with the present understanding of the hemodynamics, with the pulmonary artery catheter usage is not that beneficial. It doesn't improve the overall outcome with increased chances of morbidity. And it is sometimes very difficult for the on-duty nursing staff or doctor to pick up the changes, subtle changes in the pulmonary waves, and at the same time to ensure the catheter is in proper place. Next, so what we do from the pulmonary artery catheter, we can measure the pulmonary the dilution thermodilution technique. In case of PICO, we can do for transpulmonary thermodilution technique, where a indicator in PICO it is the cold saline. In case of LITCO, it's a lithium solution which is injected into the superior vena cava, and it is sensed as a distal catheter, distal sensor present in the arterial catheter. And by this, from the mean transmit time and exponential decay time, we can measure the cardiac output. Presently, we are using PICO in terms of EV1000 from Edward that we are using at this moment. And what they are doing after measurement of this cardiac output, for a measurement of the cardiac output on a continuous basis, they are trying to get the data from the pulse culture analysis. In the arterial waveform, they try to look at the systolic part and the area under the curve of the pulse arterial waveform, and they standardize it in terms of the transpulmonary thermodilution technique. So what are the things it can measure? It can measure the intrathoracic thermal volume. It can measure pulmonary thermal volume, and by from these two values, we can measure the global end diastolic volume, which includes the right atrial volume, right ventricular volume, left atrial volume, and left ventricular volume, which is one of the most important parameter of volume status of a patient. Along with the cardiac out preload, like I mentioned, global end diastolic volume, central venous pressure, intrathoracic blood volume, we can also look for the pulmonary edema, that is whether the extrapulmonary lung water index and pulmonary vascular permeability index. By these two data, we can differentiate between a cardiogenic cause of pulmonary edema and non-cardiogenic cause of pulmonary edema. Next, what we can measure is the stroke volume variation, systolic pressure variation, and pulse pressure variation. It is the difference of the systolic pressure and the pulse pressure between a respiratory cycle. We already discussed that at the end of inspiration it will be maximum, and at the end of expiration it will be minimum. If you look, but when you compare systolic pressure variation with pulse pressure variation, systolic pressure variation is influenced by pleural pressure along with change in the left ventricular stroke volume. But pulse pressure reflects only the changes in the transmural aortic pressure. Therefore, it is more predictive of fluid responsiveness compared to systolic pressure variation. And the studies like a systemic review regard of 5-6 studies have shown that pulse pressure variation has an area under the curve more than 0.9, which is much more sensitive compared to the other values, other indicators. What are the other modalities we have? When you compare with LITCO and PICO, which gives a continuous cardiac output, which are continuous cardiac output monitor, along with a transpulmonary thermodilution standardization. There is another modality called flow track or Vigilio, which does not need calibration by any external measures of cardiac output. Here, there is a value of the arterial compliance fitted in the system, which is calibrated from biometrics data of 1,000 patients, and it gives a continuous complex arterial pulse waveform, and from that they measure the cardiac output, and which is reasonably validated in human database. It is a minimally invasive procedure because it just need a arterial line with a special catheter. So whenever we are looking for the decision making of fluid administration, we can click for whether there is a loss of fluid or whether patient is in early phase of sepsis. Probably in this scenario, we can start with the fluid administration. Otherwise, you can look for the fluid responsiveness and the fluid status of the patient. Whether if the patient is spontaneously breathing, there is an arrhythmia or low tidal volume or low lung compliance, you can go for passive leg raising test, end expiratory occlusion test, or mini fluid challenge. If these criteria are not there, we can look for pulse pressure or stroke pressure respiratory variation, passive leg raising test, end expiratory occlusion test, and mini fluid challenge. But this pulse pressure variation has a lot of drawbacks. It cannot be applied in spontaneously breathing patient, cardiac arrhythmia, mechanically ventilation with low tidal volume, low lung compliance, open thorax, increased intrathoracic intra-abdominal pressure, and low heart rate or respiratory rate scenario. And studies have shown that when the lung has a compliance less than 30, which is not a very uncommon phenomenon whenever we are dealing with an ARDS patient, then pulse pressure variation is not that significant marker for fluid responsiveness. In that scenario, probably a passive leg raising test and end expiratory occlusion test are much better predictor of fluid status of this type of patient. And there is a very landmark study published by Dr. Shailan and Mitra from TMH Mumbai, when they have do a tidal volume challenge, and they have in a patient with a to check for fluid responsiveness, and they found that the change in the pulse pressure variation and systolic pressure, stroke volume variation with this uh, tidal volume challenge has a much higher sensitivity and specificity in predicting fluid responsiveness compared to a simple pulse pressure variation and stroke volume variation. Do we have any other modality? Yes, there is a, we also can try to assess the volume status of the patient from the venous to arterial carbon dioxide tension difference. We all know that whenever carbon dioxide, partial pressure of carbon dioxide is in a curvilinear relationship with the carbon dioxide content of the blood, and it is in an inverse relationship with the cardiac output. So if there is an increase in the partial pressure of the delta PC, the gap between the arterial and the venous carbon dioxide, that indicate probably there is a poor cardiac output. Now, when we combine this data with SCVO2 and along with lactate and other clinical situation, and if the patient has a low SCVO2 along with a high delta PCO2, it indicates that there is a need for increase in the cardiac output. And if we can, then we can go look for volume status of the patient. If the patient is fluid responsive, then we probably give more fluid. If the patient is not fluid responsive, probably we'll need to give an inotropic agent like dobutamine. So to summarize, the volume status of the patient, specifically in ICU, is really challenging. So we should always approach in a targeted manner. Like if the patient has the evidence of poor tissue perfusion and an overload, only then we should assess for a volume status. Fluid is a drug, so whenever we using it, it should have a target, and whenever it should be guided by a responsiveness concept of responsiveness and tolerance. When measuring the volume status of the patient or the fluid responsiveness, which are used interchangeably sometime in ICU, we have to learn the pathophysiology of different techniques, and we have to master a few depending on the availability in your ICU. Like in my ICU, I am more comfortable with ultrasonography and echo because that is more easily available compared to the other modalities. And among the transpulmonary techniques, probably we are using only the AV1000 because it is available. So we have, depending on your availability, we have to train yourself and have to develop confidence on few of the interventions. So by this, I like to conclude my talk. Thank you.